Good afternoon. Thank you everyone for coming. Just before we get started and before I introduce Elka Troedson, our key speaker today, I would like to thank Be Active Physiotherapy, who's a proud supporter and sponsor of the 2016 Women's Health and Fitness Summit. It's an honour to join forces with this industry-changing event and bring together professionals who are passionate about supporting women in fulfilling their ambitions. Be Active is a centre dedicated to the health and well-being of women of all ages and all physical capabilities. Be Active offers over 60 classes for prenatal, postnatal and clinical Pilates each week and has consulted to over 4,000 women at various stages of their pre and postnatal journeys. My name is Samara Naniakara and I am a women's health physiotherapist based at this clinic. I'm excited here today to be presenting Elka Troedson, who is my colleague as well, who is a physiotherapist and nationally recognised presenter, who has a keen interest in women's health and fitness. Elka started her career as a counsellor, but felt that her calling was to promote active and healthy lifestyles for today's women. Elka is also a clinical Pilates instructor and has worked in private practice both here in Melbourne and in Hong Kong. Elka designs and delivers education programs to both physiotherapists and health professionals, presenting at workshops and conferences. And as a former professional dancer and personal trainer herself, Elka understands firsthand how important it is to be strong, be brave, and be active. So without further ado, I'd like you to welcome Elka Troedson.
Thank you, Samara, for that introduction. Hi everyone, what a great weekend we've had. I hope you've been inspired by all the fantastic presenters we've had over the last 2 days. I'm really excited to be here today to present to you my experience and knowledge in abdominal separation. I love treating and assessing women that do have abdominal separation because it's a challenge and there is no recipe and every individual is different, which provides great enjoyment and fulfillment when I can make a difference to their lives with the recovery of their abdominal separation. So each layer of the muscles, the fibres run on different directions to provide specific movements. So our rectus abdominis, the muscle fibres run vertically up and down, and this is our outermost layer. Our rectus abdominis muscles are connected with the linea alba, which is the band of connective tissue through the midline that are connecting the rectus abdominis. Our second layer is our external oblique muscles, and the orientation of the fibres are running like we're putting our fingers into our front pockets of our jeans, so they're that diagonal orientation. The movement of the external obliques is that it rotates our trunk to the opposite side, so our right external obliques are rotating our trunk to the left. Under our external obliques, we have our internal obliques, and the orientation of those fibres is like we're putting our hands into our back pockets, and that's the direction that those fibres are running. The movements that the internal oblique muscles do is rotation to the same side. So our right internal oblique will rotate our trunk to the right side. Our fourth and deepest layer is our transverse abdominis. And these muscles don't move our trunk, they're providing stability and they make up part of that core or stabilising system that again we've heard a lot about over the last 2 days. The orientation of our TA muscle fibres runs horizontally, so like a big wide belt below the belly button. Pelvic floor, so in conjunction with our deep abdominals and those stabilising muscles, as we know, pelvic floor muscles are really important to make up part of that stabilising unit. The bony landmarks of the pelvic floor are from the pubic symphysis at the front to the coccyx at the back. So if you all bring your hands together like so, bringing your thumbs together and your pointer fingers, this is the rough size of your pelvic floor muscles, with the pointer fingers being your pubic symphysis and the bony attachment at the back being your coccyx. Where our thumb and pointer finger meet, these are the bony landmarks of our sit bones. If you squeeze the muscle between your thumb and your finger, that's approximately the thickness of our pelvic floor muscles. And if you squeeze your cheek, that's approximately the stretchiness of our pelvic floor muscles. So they can appear quite small, but very important group of muscles that we want to protect, especially during the pre and postnatal period. There is a really close relationship with the abdominal wall and the pelvic floor muscles. As I said, they do make up that core, and if one area is not functioning, then it can have an effect on the other area and creating a dysfunction within that core system. Same with if the pelvic floor isn't functioning effectively, the abdominal muscles might have to work a bit harder to control and stabilise that unit. So part and parcel, the pelvic floor and the deep abdominal muscles have a really close relationship with each other. So where is the DRAM actually occurring? So the DRAM is a separation of the rectus abdominis where the linea alba is actually stretching and pulling apart. So it's not actually the muscle fibres of the rectus abdominis that are separating, it's that connective tissue of the linea alba. And it's a bit like a zipper effect where it's coming down through the centre midline, right up high from the sternum and coming down to the pubic symphysis. The linea alba is connective tissue, so it doesn't have a nerve or blood supply, and it's really acting as a protective mechanism to protect the rectus abdominis, especially in the prenatal women when these muscles are stretching as the baby grows. So these are two pictures of what a DRAM looks like. And as you can see, the picture on the left, the separation is dipping down, creating like a divot. And then on the right side, which we see quite commonly, is where you get a bulge or a peaking, which is also indicating that there is an abdominal separation. What I'm going to do today is just show you a quick, easy test that we use to test for DRAM and assessing that separation of the rectus abdominis. And it would be great if I could provide you with some confidence just to use it as a bit of a screening test. If you all have new mums in your group exercise classes or your one-on-one personal training, just to be that confident to use it as a bit of a screening test to allow you to be able to refer on if they need further treatment. I'm not advocating for you to diagnose, but just by being able to pick up whether they do have an abdominal separation, it will really allow you to essentially empower your clients' lives, and you could be the first one to get them to head in the right direction to get their DRAM further assessed, which will ultimately have a positive impact further down the track. So is there any mum in the audience that would like me to test their DRAM or see if anyone has a DRAM? Yeah, we'll start with you in the red top. Yep. First hand up. So I'll just get you to lie on the floor. How many children do you have, if you don't mind me asking? One.
3 months.
3 months, great. So nice.
4 months, sorry.
4 months?
Yeah.
A fresh postnatal mum, which is fantastic to see. So I'll just get you to straighten your legs out. Are you happy to lift up your top? All right, and then just bringing your hands by your hips. So obviously the variation of how high they curl their head and shoulders up can have an impact on what's happening with the abdominal separation. So when we're doing this test, we're just encouraging the client or the patient to just curl their head and the top of their shoulders up off the floor. That's it, just like you're doing a sitter. And then just using 2 fingers to start with, we're looking at about 2 centimetres above the belly button, feeling for any separation. Just curl up a little bit higher if you can. Looking for any bulge, seeing how shallow or how deep the separation is. Yours is quite small, it's only 1 centimetre. Just going to check below them. And about 2 centimetres below the belly button. So great to see this lovely lady only has a very small abdominal separation of about 1 centimetre. Sometimes if the separation's quite wide, the higher they curl up, the separation can actually close. So there is that variability with the assessment from physio to physio, but as I said, it's just a really easy screening test to start off with, and especially if you're picking up an image like the peaking, it will happen quite suddenly, but it is a great starting point to steer your clients in the right direction. Thanks very much.
Thank you.
Does that all make sense? So very, very quick, very easy. It's not the gold standard of how we assess DRAM, but as I said, it is that really good starting point.
I've got a quick question, is that okay?
Yeah, absolutely. At any time if you've got any questions.
Cool. I just was taught initially to do the testing for DRAM with the knees bent.
Yep.
To sort of maintain a neutral pelvis. but you didn't cue that, then is there a reason why or why not we do that? Or?
I guess, standard procedure, and there are some variations. Standard procedures, we do have the legs straight because, again, with the knees bent, you are that little bit more likely to curl up a little bit too high. So more from a standardisation within a physio practice, if there's more physios, then we just keep it standard to keep the legs straight.
Okay.
So some might argue there's no right or wrong, but I guess it comes down with getting that consistency with the assessment. So we do it with the legs straight. Sometimes it's not always quite easy to feel the dram, and sometimes starting with 2 fingers you may need to add a third or a fourth finger, struggling to find those medial borders of the rectus abdominis. But in fact, on occasion, the dram might be out here, so you've really got to get your 2 hands onto the stomach to feel that separation. So I'm just making sure sometimes it's not so straightforward as just popping your 2 fingers on and then there you can feel the rectus abdominis. But as well, some of them can be really deep where your fingers sink right in, and also quite shallow. You can have a really large dram, but the abdominal muscles are functioning quite well. And you can also have a really small dram where the muscles are quite dysfunctional and they're finding it really hard to activate those core muscles, which I'll talk about later on. But just because it's a dram, it's a wide separation, we're also starting to look at the function of the abdominal muscles as well.
Sorry, Elka?
Yes.
You only take an active measurement?
Yes, yeah. So with further assessment we might add in leg extensions, also looking at pelvic floor as well, but just starting with that active measurement.
Do you ever take it at rest is what I'm asking, I suppose?
Yes, yeah, especially in the bigger separations that we do, but yeah, especially in the thorough physio assessment, we would look at that. Sometimes we look at it in standing as well, so not just lying on the backs, and then some more functional, I guess, movements as well, assessing with that. So what is considered a dram? So we're really defining a dram as greater than 2 centimetres above and below the umbilicus with that head lifting test. It is really common during pregnancy, and I guess that's why I'm here today, to inform you that almost 2/3 of pregnant women will have an abdominal separation in the 3rd trimester. And it's really great from a personal training or fitness instructor perspective that you can reassure your clients that it is very common. There are ways that we can treat and manage it, and after the baby's born we can work on getting that separation closed. So the education side of things, to making sure that your clients aren't feeling alone, like they're the only one that has an abdominal separation, is really important. It's really amazing too the number of people that don't know or haven't heard about abdominal separation. And I do talks at new mothers groups, and there's always a couple of women in the group that have never heard of abdominal separation. The abs didn't get checked at the hospital. So if it wasn't for me coming to do these talks in the community, they may have never known about what the effects of abdominal separation are. And again, within the fitness industry, if you're the first ones that they talk to and you can just educate them about that, it can essentially make a huge difference on their treatment and management and them getting back into their exercise routines. Postnatally, up to 53% of women have a dram immediately after delivery, and 36% remain abnormally wide at 5 to 7 weeks postpartum. And this is generally without any intervention, without any exercise, but just letting the body recover after delivering the baby without any intervention. When is a dram evident? So during pregnancy, the dram can start to, the interecti distance can start to increase starting from roughly about 14 weeks of gestation and can gradually increase up until delivery. In saying that though, there are plenty of women that don't get an abdominal separation when they're pregnant, or because it starts at roughly that 14-week stage, it doesn't mean it's going from 1 to 2 to 3 to 4 to 5 up until they're 40 weeks pregnant. So some with correct management, correct exercises, and various modes of modality to manage the separation, it can just stay at a certain size without gradually increasing as well. Natural resolution and greatest recovery of the dram occurs between day 1 and 8 weeks after delivery, and this is where early intervention is really beneficial, because essentially we're trying to reduce that time where they hit that plateau. And if we can start introducing dram correction exercises, they're going to recover and get back to their full function, return to whatever exercise they love to do earlier on, as opposed to having that longer period where they're not doing anything, and that's where they notice that their drams are not really changing. So what causes a dram? Especially in the prenatal women, there's lots of hormonal changes happening. The relaxin hormones are releasing, which is softening the connective tissues, softening the ligaments around the joints. So because of these hormonal elastic changes, it is putting that more stretch and flexibility on the linea alba. The mechanical stress of the fetus, growing fetus, does place a bit more stress on the abdominal wall. As that baby gets bigger, we notice and we see that the abdominal muscles are stretching even more. To allow room for the baby inside the abdominal cavity, sometimes the abdominal organs have to shift a little bit to make room for that growing fetus. And because the muscles have skeletal attachments on the rib cage and pelvis, as the rib cage widens during pregnancy, this is also placing stress and stretch on the linea alba and those rectus abdominis muscles. And that's what we call a dram, especially during pregnancy, is that these muscle attachments, the distance between them are increasing. So there are some various factors that contribute or cause a dram. Some of them are a bit beyond our control. There's nothing we can do about it, but through education and advice, we can also try to make a difference. The first one being close pregnancies. And I guess if ladies fall pregnant quite quickly after their previous pregnancy, it really does come down to the recovery in between each pregnancy. So ideally, if the abdominal muscles close and that dram gets a bit smaller, then essentially for that next pregnancy, we can reduce the risk of that separation getting even bigger again, because all of these muscles are being stretched in the previous pregnancy. Over and underuse of abdominals, and working in the fitness industry and as physios, we see this a lot, and especially those new mums, they're dying to get back into their exercise classes after they've had their baby. And I had a client not too long ago who again was really keen to get back into her exercise. She wanted to lose that mummy tummy. She went to her first high intensity exercise class, and one of the exercises was that she had to do quite a few abdominal crunches. As she was doing that first set, she felt a tearing sensation through her upper abdominals, and it was quite painful. And essentially, she gave herself a dram. So what was happening is she was overusing her abdominal muscles that little bit too soon, which essentially placed more stress on the rectus abdominis and just tearing that linea alba again. The opposite of overuse is underuse. So some of our clients, they can be quite sedentary even during the pregnancy. They haven't used their abdominal muscles or remained quite active. The physical demands, once they're caring for their newborns, lots of lifting, bending down onto the floor, getting up from sitting to standing, holding their children. So we really need to use our abdominal muscles to support our trunk and to do these activities. And because of the underactivity of being quite sedentary, this client in particular was finding it really hard to do those quite specific movements, even just changing positions. So because of that underactivity, she was putting more stress onto her rectus abdominis and that linea alba, just because she couldn't get that activation from her stabilising muscles.
Jump in. Is there any research, or in the studies of the research, because I'm not up with it, to indicate that doing more exercise does actually have any true effect on progression of dram or propensity to get it?
During pregnancy?
During pregnancy, because I always get that question, did I not do enough?
Yeah.
Did I possibly cause it?
Yeah, I think there's that fine line of doing too little and then doing too much. So with the statistics that almost 2/3 of women in their third trimester do get a dram, I think some of the research is saying that what exercise they're doing is providing that it's correct exercise, that it doesn't change whether they're going to get a dram or not. And I think with the correct exercise during the prenatal period of strengthening the core and having those stabilising muscles work, then that is good management with regards to allowing the separation from getting too big. But I think from what I've read in the studies, there aren't specific guidelines as to what's too much and what's too little.
That was my understanding of where it was at presently as well, that they really don't know yet what is that fine line.
Yeah.
I think for the group too, I think genetic predisposition's a big one.
Yes.
As well. I'm sure you found in certain markets you'll get greater tears in your Indian groups.
Yes.
Changing connective tissue.
Definitely, yes. Yes.
Depending on your definition of a dram too, there is a paper that came out last year or this year that said basically 100% of women who were examined had a dram. So.
And at what stage of the pregnancy?
By 37 weeks.
By 37.
37 or 38 weeks.
They kind of was like 1 point.
Yeah, just any increase in separation.
Yeah. It was only small. So
Yeah.
It wasn't the 2 centimetre definition.
Yeah.
Basically everyone widened.
And I think that's the thing too, is that definition of the dram, whether it's any separation or greater than 2 centimetres, and those studies can vary with that.
When you measure it and how they measured it.
Exactly, yeah.
So many varieties.
Yeah, absolutely.
Because also that's what the body is supposed to do. It's making space
Yes, yeah.
for the baby. So it's actually quite a normal thing.
Yeah, and it is a response because it's protecting the rectus abdominis muscles. So in order for the fetus or the room for the baby to grow, then we need this separation. But I guess as we know that it is common, it is likely to occur, we just want to encourage our patients that we don't want it to get humongous, because then their recovery afterwards is that little bit slower. Intra-abdominal pressure and lifting. So even just the nature of lifting a few kilos, as we know, whether it's baby or weights at the gym or even moving house. A lot of my clients like to move house at 39 weeks pregnant. So with any lifting, it really is increasing the intra-abdominal pressure. And with that, it is placing stress on the abdominal muscles. So that's why we're really encouraging to inform our clients that err on the side of caution with any heavy lifting because of the extra stress and that increase in the abdominal pressure. Weight gain, so we are seeing this naturally with pregnancy. Weight is going to get put on with the pregnancy, but again, in conjunction with it not letting it get out of control, we just want to minimise how much stress is happening on those abdominal muscles. And occasionally in the clinic I'll see male patients that have abdominal separation, whether it's from exercise or because they are overweight, and they're the men that are quite likely to get hernias in the umbilicus because they have that separation through the rectus abdominis. Genetics is an area, as Alex just mentioned, that is a bit beyond our control, but just keeping in mind certain nationalities can have variations and be more predisposed to abdominal separation. Also, if you see new mums with stretch marks or striations over their abdominals, they are generally at a higher risk of abdominal separation. And as Alex said as well, Indian ladies are very common, and it's a pattern that we see that they tend to have stretch marks on their stomachs. And even if they're very petite or of normal frame, it's just the nature of their collagen makeup and their skin type.
And redheads as well, okay.
Yes, redheads, pale skin redheads, yes, can also be that little bit more susceptible. Large babies and multiples, I guess, goes without saying. Those muscles are just put under even more load because there's 2 or 3 little bubs inside, so those muscles are stretching even more. And gastrointestinal issues. I know food intolerances, food allergies are so prevalent, and we're more informed of the effect that these have on our guts. So even with these side effects, with the bloating, the constipation, that discomfort, that is all creating that little bit more stretch on the rectus abdominis muscles. And that's why it's really important that we do liaise with the dietitians or refer our clients onto a dietitian to get their gut sorted. Because if we're just focusing on the muscular systems and paying attention to that, but their gut issues are still out of kilter, then essentially it can be a bit counterproductive because they're still going to have that bloating, that discomfort, and feeling like their stomach's really sticking out, which we can do all the training we can with the deep abdominals, but the diet side of things is also really important. So if you have a dram, that can also lead to certain issues. And that's why with the education and the management, we're trying to reduce the risk of them getting any of these symptoms. Hernia is most commonly above the umbilicus, is what we quite commonly see, especially in the physio setting. It can lead to back pain because essentially we're losing support through the abdominal wall, so our back muscles are having to work a lot harder. Same with the pelvic floor muscles. If any of you were in Julie's phone conference yesterday, we saw a great image of what's happening when the abdominal muscles are pulled in and what's happening on the diaphragm and pelvic floor. So again, it's all connected and can lead to dysfunction in other areas. Pelvic girdle pain as well, because we're losing that support system through those stabilising muscles. Postural problems, as I mentioned earlier. A protruded stomach, so this is where self-esteem really is a great way, as fitness instructors, personal trainers, physios, that we do a lot of exercise, that we are trying to build the self-esteem of our clients. And a lot of them will come to you and they're feeling really down and out because they're still looking pregnant months later after having their baby, complaining that their stomach's still sticking out, that they're feeling bloated, and this essentially is making them feel self-conscious and lowering their self-esteem. And that's where, again, you have the ability to really empower them that with the correct exercise we can make a huge improvement on their self-esteem. The cosmetic effects, especially with that abdominal peaking, you can imagine if you're at the beach in your bikinis and you get this doming effect every time you sit up from sunbaking, it's not a great look. And also it's destabilising the support system. So with the abdominal walls, the pelvic floor and the diaphragm, we are losing that bit of support, so those other areas are having to work a lot harder. And if it does get avoided or unattended, then future aches and pains further down the track is also something that the DRAM can contribute to. So with the assessment, as a physio, we do a really thorough assessment. As I said, it's not just the quick 2-minute DRAM check, getting them to curl their head and shoulders off the floor. So we spend a good 45 minutes assessing the client on an individual needs, getting their goals and really finding out what's bothering them about their abdominal separation. Not only are we looking at the width of the abdominal separation, but also looking at the depth as well, with the functional movements at rest, as Anthony mentioned, and also using the real-time ultrasound. So the real-time ultrasound is a really great piece of equipment that allows us to look at the deep stabilising muscles in the abdominal wall, and we also look at the pelvic floor as well. On the ultrasound, we don't look at the rectus abdominis because the ultrasound heads that little bit further out to the side. But as you can see, this picture on the left, you've got 3 layers of muscles. So 1, 2 and 3. This top layer being external oblique, and then we have internal oblique, and then transverse abdominis is this thinner one here. Up here is where the linea alba, that connective tissue, is. So what we're looking for on the real-time ultrasound is whether there is any overactivity through the oblique muscles and whether they can isolate that TA contraction and they're getting that good lateral glide of the muscle fibres. And the TA muscles are attaching to the spine and the lower back, which is why that strong TA can reduce back pain as well. So this image on the right is with a TA activation. So you'll see that the 3 layers of the muscles are getting pulled to the side, so that linea alba is tightening, and then TA is getting a little bit thicker and again getting pulled to the side. So as it turns and drops off at the side, that's where it's wrapping around to attach to the lumbar spine. So it's really a great gold standard way for us to look at the integrity of those muscles, and we're also starting to see more research done at what's happening at the linea alba when we're activating the TA muscles. The latest research, this study came out in July this year by Diane Lee and Paul Hodges, and they were looking at the behaviour of the linea alba with the curl up in women that had abdominal separation or a DRAM. And what they're starting to research is that we shouldn't really start to rule out that curl-ups are a bad exercise to do for ladies that have a DRAM, but further down the track in their treatment procedure, start to look at the benefit of doing a curl-up and what it can do on the linea alba. And what they found is that with the pre-activation of TA, before they curled their head and shoulders up, it was actually narrowing the interector distance because it was pulling the rectus abdominis down, so that way, which was essentially narrowing the interecti distance. So the final comments on that research paper was, we don't yet have the perfect exercise program for the treatment of abdominal separation, but it's certainly something that we shouldn't start to rule out later down the track to start reintroducing curl-ups in their exercise program.
I think you've got actually raised a really good point here. And,
Sorry.
I've got lots of women who have had very weak RA borders and you can't even palpate or know what the interectile distance is because you can't palpate the RA.
Yes, yeah.
And I just often wondered about those women who are really lengthened through the RA, what we could do to actually reduce the length, and would sit-ups be indicated, as you just suggested, towards the end of the rehab process to reduce the length of the RA back down?
Yeah, to try and shorten the muscles, and I think with the rehab programs we do want to reintroduce those exercises because ultimately our clients want to get back doing their sit-ups, doing their crunches, doing their planks without knowing that they're actually putting any or making things worse. So that's why we do want to be that confident that we can start to reintroduce those exercises later down the track. And essentially, you're right, it will have a shortening effect on the rectus abdominis muscles as well. So I guess the importance, as we've just spoken about, is the tailoring and modification of the exercise programs. And there is no recipe, but just having some variations that we know are safe on the abdominals so that we can modify those exercises. And I guess in the individual setting, if you're in a one-on-one session, it is quite a lot easier to modify and really be specific with that client. But I guess in the group setting, it is that little bit more challenging because of that variability. So I guess my recommendation with that would be take the conservative approach initially, especially if you know there are quite new postnatal mums out there. Just on those first few sessions, err on the side of caution and be that little bit conservative and see how they respond to the exercises and then progress from there. So we've seen these exercises, we love to do them, we feel the burn, they're very popular, they're working our abs, they're strengthening our ab muscles, but probably in the prenatal clients we tend to avoid these exercises because they are putting a lot of stress and increasing the intra-abdominal pressure and making those rectus abdominis muscles work a lot harder. So we'll start with sit-ups. So I'm just going to go through a few variations that you probably may have seen or may not have seen, but feel free to write them down as good variations that you can use. And some of them will be suitable for postnatal mums as well, that are great exercises that we can use as opposed to the general sit-ups and real rectus abdominis exercises. I'll get lovely Samara over here to demonstrate some variations. So the first one, as opposed to a sit-up, I'll get you lying on the floor. So knees bent, so a good variation, really focusing on that TA activation, is just starting with a nice simple leg extension where they're extending one leg out, not letting their lower back arch, keeping their rib cage down, but really focusing on those deeper lower abdominal muscles. And then bringing the leg back in and then alternating sides. So nice and simple but effective, getting those target muscles working but not putting any stress on their DRAM if they have one.
So that's your starting point there, or you start off with that, like a basic primary exercise?
Yeah, so that would be very basic. Even prior to that, you could just get them lying there, knees bent, activating TA, and then release, and then starting to introduce leg extensions. From there, progression would be the bent knee fall out, so keeping the knees bent and then dropping one knee out to the side, so as far that the hips don't start to rotate, and really getting that strong control and stability around the pelvis. Making sure that they're not holding their breath as well, and focusing on those deeper abdominals. From there, we tend to progress, or a little bit more challenging is coming both feet up into tabletop. And then coming into heel touches. So just keeping the knees at 90 degrees, lowering one foot down, and then alternating sides.
So is that when you have your hand on your tummy, looking at the intra-abdominal pressure to see if they're able to...
Yep, so we can check, even some ladies that have quite a large DRAM, this probably isn't that suitable initially.
Yeah.
So again, making sure that it's specific for the client. But yeah, watching that they're breathing, they're keeping their ribs down, placing your hand on their lower back and their stomach, and seeing if there's any peaking and feeling for that intra-abdominal pressure.
You'd be cueing TA at this point, or...
Yes, yeah.
Pelvic floor or exhale.
Yeah, exactly. With cues.
Normally, would you jump to a double leg? In reality, with your clinical patients, how many weeks normally by the time they're able to control that?
Yeah, probably close to the 12-week mark.
So there's often a fair bit before that.
Yeah.
Yeah, your side lie, really nice double leg lift,
Yeah.
as well.
or functional.
Yeah.
Because certainly double leg lift is always contraindicated
Yes.
because it's raises intra-abdominal pressure.
Exactly.
That's why I questioned that, but I can see it's a progression.
Yeah. Yeah.
But yeah.
And
And definitely with the tuck under, you know, we want to bring rectus on first, yeah? So by doing a posterior pelvic tilt, shorten the muscle, get it in a better action, you know, when you talk about active range through biceps, get in its optimum range to work, and you're safer. But personally, for me, double leg, I prefer functional stuff. They're picking up their babies all day.
Yeah.
Do all of that before I even go to anything there. Yeah.
Recent research just come out actually, not that long ago, showed that in Pilates, double leg lift, as well as double leg on a reformer. Now, I don't think it was postnatal at 12 weeks or anything, but it showed that getting up and down off a chair was more pressure and more load on via the intravaginal transducer pressure.
Yeah, but how are they? Sorry, is to test. So how are they getting up and down off the chair? Wasn't it off the floor? Oh, it was a sit to stand. Oh, it's because of that. Yeah, absolutely. So relative, what are we doing?
Well, what they did in the study was they calculated what a post-gynae operation patient would do every day, and they calculated that 1 hour of Pilates exercise is less pressure on your pelvic floor.
I suppose the key difference is that your pelvic floor is still potentially lengthened if you've had a vaginal delivery, and potentially vulnerable, we think, we don't know, we think up to those 12 weeks.
Yeah.
And that's the point where the organs aren't supported. So that'd be I agree with you, Andy, but that'd be the only difference that I'd say in that early postnate, why we're all so cautious.
Sit and stand 20 reps in a row. You probably do it a few times over an hour a day. Whereas you might do 20 reps of an exercise.
Yeah.
Just one other thing. I'm fairly cautious with adding posterior tilt when I'm doing abdominal stuff because of the amount of women that are getting hypertonicity around pelvic floor issues. So I think if I put them into that pelvic tilt, it encourages that puborectalis to come on a lot with the RA. I tend to, in these positions, bring the legs slightly in from vertical and compress down through the femur to give them more support in their lumbar spine when they lift their second leg. So that, because I find tabletop, for most of my women, even at 6 months, is actually quite it's quite challenging to lower one leg from tabletop and not actually, to do it well. To do it well. And some fit women can, but the majority of women that would come would be of average fitness. So I think, or using the fit ball still to get that tabletop support.
Definitely. And these are progressions that it doesn't go one after another. It's just variations that sometimes we have to take them a step back because they're really keen to get into those more challenging exercises. And even though it's quite simple to us, as you said, when you get them doing it with that control and that correct movements, it is quite challenging with those. Even for the pregnant woman, just sitting on a fit ball. Samara, I'll get you to sit on a fit ball. So challenging their stability, getting balance involved, even just sitting up nice and tall, activating the deep abdominals, and then lifting one leg. And you'd be surprised how challenging it is, especially if they're heavily pregnant towards the end, and getting them just do these simple stabilising movements. All right, planks again. So some would argue maybe even planks on the knees that this should be an okay exercise, but depending on the size of the dram, with gravity you're getting everything pushing down towards the floor, and that can also place stress on the rectus abdominis. So a nice variation for that is some rollouts on the ball. So placing the elbows on the ball. And again, not suitable for everyone. This may be months down the track, starting to introduce this, but starting to work those abdominals a bit harder and really watching that they're not pushing out too far, using their lower back and keeping that control through the lower abs. Again, watching planks on the knees. It's an individualised basis, but just erring on the side of caution, especially with pregnant women. We don't do any planks on the knees because of that gravity pushing down on the rectus abdominis muscles. Push-ups, so a similar motion, but some great variations using the ball on the wall, coming into a push-up on the wall. So really focusing on the upper body, squeezing the shoulder blades together. And as the elbows bend, really engaging those deep abdominals and the pelvic floor. So again, it's not about building up the strength of the chest, but working on the posture, the upper back, but safe for the abdominal muscles and the pelvic floor. Thank you. Another great one as well, pre and postnatal, we use them with both, is the opposite arm and leg lift with the balls. So you can use it just hands on the wall. Even if you're outside doing outdoor training, you can use a tree, but coming into an opposite arm and leg lift on the ball, which is great for stability as well. Running or any high impact exercise is naturally putting stress on the pelvic joints and the spine. So this high impact exercise is also increasing intra-abdominal pressure. So that's where, especially those first 3 months postnatally, we are really encouraging of our new mums to stick with low impact exercise. Because of all the hormonal changes, pelvic floor is still a little bit weak. They're working on their pelvic floor, but we don't want them to put those muscles under any more stress by getting back into the high impact exercise too soon. It's really important too, when we start introducing the exercises, that you're monitoring your clients for fatigue. And it's really important that we don't just get them to pump out 20, 30 repetitions where those last 15 they're really struggling, they're using their back, they're collapsing through their back, they're tensing their shoulders, because essentially they're not going to get anything out of those exercises. So if you can monitor your clients for fatigue and work with their number of repetitions, that they're getting the most out of their exercise program. With any type of weights types exercise, again, initially we just lighten the weights and then gradually get them to build up. And if they can't engage their pelvic floor and their deep abdominals while they're doing those weights, then those weights are too heavy to start with. So these are traditionally abdominal cues that we hear over and over again, and especially when we're treating and managing abdominal separation, we try to avoid these cues. Everybody sit up nice and tall and brace your abs. Squeeze as hard as you can, harder, harder, harder. What's happening?
Pressure.
Pressure? Anything else?
Your breath's moving to the upper chest as well.
Yeah, or you're not breathing at all, I find. Yeah. And where can you feel that brace happening?
Pelvic floor.
Pelvic floor everywhere, yeah, rectus abdominis quite high up. And this is what's happening when we instruct our clients to brace their abs and squeeze as hard as they can. And we really want to get them to activate their deeper abdominal muscles and stay away from recruiting those more superficial muscles, because that over and over again is going to increase the intra-abdominal pressure, put more stress on our pelvic floor. Pull the belly button in. Everyone, suck your belly button in. What do you feel? Pressure?
External muscles.
Yeah, external muscles. Are you breathing? No. So again, it's the same mechanism that we want to avoid, but it's amazing if you do it, you realise that rectus abdominis wants to jump in straight away, and you can't even feel TA or those deeper muscles doing anything. So we can imagine with higher repetitions of exercise that this is just going to be placing more stress on those muscles. So with our cues, we're really focusing on that gentle activation, and sometimes with clients I need to use 2 or 3 variations for them to really get the hang of the correct muscles that they're activating. And the nice thing when you're working one-on-one and in the physio environment is we can real-time ultrasound them every session that they come in to make sure they're doing the activation properly, and even wheeling the real-time ultrasound out into the gym and getting them sitting on lying on the reformer and popping the ultrasound on their tummy. And I know that in the gym environment or with personal training we don't have that access, but really focusing on those gentle cues, you'll find they'll get a lot more of an accurate activation of those deeper abdominals. So gently drawing in below the belly button and really focusing below the belly button to the pubic bone, feeling your hip bones pulling towards each other. So that drawing in sensation. Imagine you're zipping up a tight pair of jeans and you're trying to get that zip to the top. Could be a bit of a worry if they're wearing high-waisted jeans though, so just remind them that they have to be hipsters. Imagine you have a belt on and you're trying to pull that belt tighter just by 1 or 2 notches. So with all these cues, you'll find that you'll still be breathing, you're staying relaxed, you won't feel any activation through your rectus abdominis, and you're getting towards those deeper layers. A nice one that we use in the prenatal classes in that prenatal environment is imagine those deep abdominals are hugging your baby. So it's that nice gentle drawing in, and they can feel those muscles giving their developing baby a good hug. And then focusing even lower down to the bikini line area and focusing on drawing the abdominals in from there is a really easy and beneficial cue that a lot of clients seem to get the hang of. So we're just going to go through some TA activation now just to feel the difference from those bracing mechanisms that we did a few minutes ago. So sitting up nice and tall. And keeping in mind, I haven't touched on pelvic floor too much today because I know there's been several sessions over the weekend, but when we are cueing TA activation, we're always cueing the pelvic floor first because with that stabilising unit, we want both of those muscle groups to be activating. So in a seated position, sitting up nice and tall, remaining relaxed and just breathing at a normal breath. Feeling your posture, shoulders down and back, and being in that upright position. Just place your hands on your hip bones and then move in slightly. Alright, so just keeping that normal breath happening, sitting up nice and tall. Gently squeeze and lift your pelvic floor and then drawing in those lower abdominals. Feeling the muscles underneath your fingers engage and then relax. Relax the pelvic floor as well. Good, one more time. Keep that normal breath, sitting up nice and tall. Gently squeeze and lift the pelvic floor and then drawing in those lower abdominals below the belly button around the bikini line and then relax. Could everybody feel movement under their fingers when they're activating those muscles? Great, so that's essentially your effective TA activation. You're still breathing, you can't feel rectus abdominis, and hopefully you're not getting that downward pressure through your pelvic floor. And if you start to feel your pelvic floor drop off a little bit, then we just need to work on the endurance, but keeping in mind that we are encouraging pelvic floor activation with the TA activation.
Sorry, is that how we can test on our clients, as if we ask them to do a pelvic floor exercise like externally? So they say, is that how we can externally assess them, by placing our hands there on their hips to feel that they're activating their...
No, so with your hands near your hip bones, you'll only feel the TA activation. You won't feel pelvic floor.
Yeah, just the TA, not the pelvic floor.
Yeah. So we can't see you engage your pelvic floor. It's all internal, and that's where if they're unsure, they're reporting to you that, oh, I'm not sure if I'm engaging my pelvic floor properly, or I feel like I'm pushing down, or might be a really good opportunity for you to refer to a women's health physio to have more of a pelvic floor assessment. And that's where, again, cues with pelvic floor can vary as well, but it's the same sensation that it's very gentle, so you're not holding your breath and placing more downward pressure on those muscles. So with the physio management, as I said, we can go into the treatment room even in an exercise session. We can use a real-time ultrasound as much as we can, and we can really devise these exercise programs on an individual needs. We're also very supportive and encouraging of support garments, and a lot of prenatal women will wear a tubie grip during the pregnancy, which helps support the abdominal muscles, and then garments like the SRC recovery shorts afterwards in that postnatal period is a really great way to assist in the recovery and treatment of abdominal separation. Education is a huge thing, especially in the health and fitness industry. It's amazing how much education can make a difference on our clients' lives, and just them having that understanding and that knowledge that you can pass on to them about the effects and the causes of what's happening, especially during their pregnancy, and some guidelines with what they can do afterwards as well. The correct TA activation as well as pelvic floor is really important. Initially in those first treatment sessions, we're really focusing on getting that correct activation, encouraging good posture and making sure that their breathing is effective and that they're not breath holding when they are doing any exercises. So here is my patient Sally. She has 4 children. She's 37 years old. Her kids are aged 6, 5, 3 and 1. And all 4 pregnancies were natural deliveries. So her risk factors are her pregnancies were quite close together. Her second child was really heavy. At 5 years, he was already weighing over 20 kilos. So with that, lots of heavy lifting, especially as he was quite young in those early few years. She reported stress incontinence, especially with exercise and occasionally coughing and sneezing. She was complaining of back pain quite regularly, and she also had an umbilical hernia. She was running about 2-3 times a week, quite short distances, about 2 kilometres, just to feel like she was still keeping active, but not realising that this essentially was having an effect on her abdominal muscles. And she was really reliant on wearing tubey grip just to feel held in. She was quite self-conscious about having her stomach protruding when she was standing, and just feeling like, from an image perspective, that she wasn't feeling so great. So on assessment, her dram was 4 centimetres above her belly button with peaking, and 2 centimetres below. And even getting up off the bed and sit to stand, she was always tensing her rectus abdominis and really bracing everything and using those global muscles as a strategy to change positions. On ultrasound, her TA on the right side was quite good, so she was able to isolate the activation. She was getting that good glide, but her left side, her internal oblique, was really overactive, and that TA, when we were watching it switch on the ultrasound, it was quite slow and sluggish. Her endurance, even of just activating TA without any movements, was about 8 to 9 reps before she really started to fatigue, and then using those global muscles again. So her treatment again was a real ideal situation, I guess, and I was quite lucky that she was very determined and motivated. A lot of the time I'll have clients come in that they want to get their dram fixed and they want to work on improving it, but they're just so busy they don't have time. They're running around after their kids, whereas they really need to devote that time to getting those muscles working effectively to get the best outcome. And it really is like an injury. Essentially it's rehabilitation, that it is a program, a graded exercise program to get that abdominal separation and her abdominal wall functioning properly. So she wore compression garments, the SRC shorts, 24 hours a day for 8 weeks, so she was even sleeping in them. And then after that 8 weeks, she was just wearing them during the day for 4 weeks. She was attending the clinic, and I was doing a one-on-one session with her twice a week, where I was progressing her exercises, and we were starting to get to quite more functional exercises, because her 4th child still needed a lot of carrying and lifting, so it wasn't very rigid, quite basic exercises. That was starting to become more challenging, and the importance of functional exercises as well with these dram correction programs is really important. In conjunction with her one-on-one sessions, she was doing her home exercises twice a day, and they were quite similar to the exercises we were doing in the clinic, and again following a progression. And she had a TheraBand at home, a Fitball at home as well, so that also helped, that it was providing her with a bit of variety. She was avoiding heavy lifting as much as she could, and she stopped her running a couple of times a week. So after 6 weeks, we were already starting to see fantastic results, and I was ultrasounding her every second session when she was coming into the clinic, to just making sure that she was getting into the routine of activating the correct muscles. And it was amazing just with that repetition as well, and seeing her muscles on the screen, that automation of a brain switching the muscles on straight away was so much more automatic. So at 6 weeks, her dram above the belly button had reduced to 2 centimetres. And this image here, this was just at rest, her standing there. You can already see it's quite an improvement of the look of her stomach compared to the first assessment session. She was really quite upbeat. She was starting to feel a lot stronger, that little bit more confident. Her back pain had reduced, probably in conjunction because she wasn't lifting as much anymore. The protrusion was less. And on ultrasound, that TA on the left side was really picking up the speed of the activation and being quite symmetrical with the right side. Her endurance of her repetitions was up to about 12 to 15, and with some exercises she was getting through a couple of sets. And then at that last session that I saw, and there were still some sessions to go, we were aiming for her to return to some short jogs in approximately 1 month's time. So this happened a while ago. finish my presentation for today. She was going overseas for a couple of months, and I thought last week, oh, I'll just send her an email just to see how she's going, because I knew that she was still overseas. And she wrote back, and guess what? She's pregnant with number 5. So I thought, oh no, all this hard work, she's worked so hard, is it all going to be undone? But I guess looking at it from the positive side is she's allowed her dram to get a bit smaller to then prepare for this next pregnancy. So
muscle memory as well from what you've already
exactly, yeah, absolutely. And I think, yes, one step forward, few steps back, and her approach from a prenatal perspective will be different. Her exercises again will be modified, but I guess looking on the bright side, then maybe we can manage that this time around the dram doesn't get too big, and her recovery afterwards is a lot quicker. But I did have to laugh. Maybe 4 wasn't enough that she was going for a number 5, and I loved her honesty that she let me know. So that was a bit of fun. I had to have a laugh. So when is the abdominal wall back to full function? And it's really important that we reassure our clients and our patient that the rate of recovery varies so much between women to women. And I wish we had that magic number that every women's abdominal separation closed after a number of months, but unfortunately we don't. So reiterating that it is, again, varied depending on the size and all the other factors, that it can vary even from 3 months to 12 months. It's a huge difference depending on the women. When a dram's less than 1 centimetre, functionally then I feel quite confident to start, providing that their activation of their muscles is correct, they've got good control, they don't have any symptoms of back pain or pelvic floor issues. I tend to find once it's less than 1 centimetre, I feel quite confident that I can start reintroducing more challenging exercises, getting the obliques going and starting to reintroduce the rectus abdominis. And this might be 18 months down the track. Making sure that there's no lumbopelvic pain or pelvic floor issues, because even from the pelvic floor side, then we might still need to be that little bit conservative, and keeping in mind that it is going to have an effect on the abdominal wall and its function. And making sure that with activation they are continuing to activate their TA and pelvic floor correctly as those exercises become more challenging. So when to refer, I remember in the goodie bags yesterday, I think there was some referral pads that really provides an easy communication tool to refer on to a women's health physio. And if you're that little bit unsure, definitely liaising with a physio to get some further assessment and treatment. So generally if the dram's 3 centimetres or larger, or they're getting some peaking and you're just not quite sure whether the exercises you're doing may be slowing down their progress or inhibiting it. If they keep complaining to you about abdominal or back pain, then it might be a great time to refer on to the physio. Pelvic girdle pain as well, because essentially this is going to have an effect on the abdominal walls and whether they can activate their muscles correctly. Pelvic floor symptoms such as prolapse, stress incontinence, especially incontinence with exercise or coughing and sneezing. And I know sometimes it's not always spoken about, but really asking your clients or getting them at the end of the session or before the session to come talk to you, and then even in that private conversation you can encourage them to see a women's health physio. If they're pregnant and you're just not sure what to do, or if those clients, those challenging ones, they just can't get their abdominal muscles back or they can't lose that mummy tummy, then that might be a good indication to liaise with a physio. Especially weekends like today, it provides a great opportunity for allied health and fitness professionals to work together, and we love collaborating with fitness professionals, and essentially we're all working together to get the best outcomes for our clients. And I feel really fortunate today to be able to talk to you and pass on my knowledge about abdominal separation, and hopefully you can just feel that little bit more aware that there are ways to manage and treat abdominal separation and allow our clients to get back to full recovery. Some references, quite a lot of them. Well, I guess if there's no questions, thank you all. I know it's been a long day, and I'll look forward to hopefully seeing you at another summit in the coming years.